those who want to pursue a specialty in pharmacy practice. And some areas that we have postgraduate year 2 residency training currently here in the United States would include areas such as critical care, infectious diseases, cardiology, emergency medicine, solid organ transplant, ambulatory care, psychiatry, oncology. There's so many that I didn't even have space to include all of those. But again, what that means is that upon completion of a first year general residency, the individual would then go on to a second year training, which is much more advanced. So advanced training in a specialized focus of area, which would then prepare them for that type of a role as a specialist, we call that a clinical specialty pharmacist in that area. Certifications, there are certifications that are also optional. So again, many of these are optional for pharmacists. And again, it's really more for credentialing, job opportunities here in the United States. The first and probably the gold standard is the Board of Pharmacy Specialties. So the Board of Pharmacy Specialties certification offers a very comprehensive exam, which I will go into a little bit more detail. We also have the American Society of Health System Pharmacists, which is the accrediting body for the residency programs here in the United States. The ASHP, which I'll abbreviate, offers many types of certification courses. We also have the American Pharmacists Association, which is APHA, and others. Other professional societies would include infectious disease, diabetes management, cardiovascular disease management. So again, the opportunities for pharmacists to pursue residency training, board certifications, and other types of professional certifications are numerous here in the United States and highly valued as well. So just a brief history of pharmacy education in the United States. When I last looked, there are currently 140 colleges, schools of pharmacy in the United States. As I mentioned, that Doctor of Pharmacy now is the entry-level degree. So since 2000, all universities had to make that transition from Bachelor of Science over to the Doctor of Pharmacy degree. So the Doctor of Pharmacy degree is now the standard. Bachelor of Science or BS in Pharmacy has been removed. Many universities around 2000 and beyond had included something called the Flex PharmD program. So what that means is that they allowed those who had current BS degrees, who are currently practicing as a pharmacist, to go through night courses, maybe even online courses, to then fulfill the requirements for graduating with their Doctor of Pharmacy. I believe since in the last 10 years, that probably has ended, since now most programs, all programs, in fact, in the United States now only allow the Doctor of Pharmacy degree as their terminal degree for pharmacy programs. So you won't find Bachelor of Science here in the United States anymore. Now, in terms of accreditation for colleges, for schools of pharmacy, we go by the Accreditation Council for Pharmacy Education, which is also known as ACPE. And the Accreditation Council sets 25 standards for both didactic and experiential education for education in the United States. So every university, every college of pharmacy in the United States has to abide by these 25 standards. They have to meet the standards, and they have to go through a pretty rigorous accreditation cycle visit. So again, in the last 10 years, I've participated in at least 3, to my knowledge, ACPE accreditation visits, where they come to evaluate the program. They come to review rigorously in terms of the didactic curriculum. They even come out to some of the experiential clinical sites to see where the students are going for rotation. They get a chance to interview faculty. They have a chance to also interview with students, where students are allowed an opportunity to provide feedback in terms of their experience, their education, the level of interaction that they may have with their faculty. So these are all part of the accreditation site visit. The maximum accreditation cycle for colleges is 8 years. So when a university, College of Pharmacy receives 8 years, it's a wonderful experience. It means that they have met the standard. Back in 2016, they implemented a few new focused goals, focused standards, looking at patient-centered care, interprofessional teams, evidence-based quality improvement, and informatics. And I can say, as a member of the Department of Pharmacy Practice, the importance and the value of interprofessional teams. Currently in our university, we are associated with a medical school, so we do have the luxury of having our pharmacy students paired with medical students. We also have a physical therapy program. We also have a physician assistant program. So we have different disciplines here on our college campus, which allows our students an opportunity to work interprofessionally with other students from other programs. And while they may be limited in terms of the number of courses that they can take together, we do offer quarterly types of courses, quarterly courses where they can interact and work together and have a chance to know what it means to work alongside a medical student or a physical therapy student. So as I mentioned, the education today for pharmacy students, didactic curriculum for the first 3 years focuses on the main courses, which would include medicinal chemistry. We also look at pharmacology, pharmaceutical calculations, pharmacokinetics, and perhaps the biggest area that we emphasize is pharmacotherapy. So our licensing exams, even the board certification exams, all heavily rely on the students' knowledge of pharmacotherapy, how they are able to apply clinical decisions to disease state management. So again, that's the role of the pharmacist. I often tell students that's the bulk of what we do. The bulk of pharmacy practice is pharmacotherapy. And if you speak to physician colleagues, I work with alongside many doctors here at my hospital, they'll say that the largest value is placed on their drug knowledge. So drug knowledge, disease state management, because that's where physicians practice and that's where they come to rely on our pharmacists, colleagues, especially for their knowledge, their expertise. I often tell students, my students, that we are to be the drug expert. You don't have to know anything, but you should be able to look it up and you should be able to know where to locate these resources and be able to provide an appropriate response to a question, whether it's from a nurse, whether it's from a physician, whether it's even from a patient or a family member of a patient. So we should be well-versed in our drug knowledge. Other courses that are included in pharmacy education include biostatistics. We also have practice labs where students have an opportunity to learn about compounding, how to prepare IV intravenous medications. We also incorporate business courses for those who want to pursue business degrees or maybe even starting up their own pharmacy practice business, community practices, toxicology, adverse effects of drugs, and also law and ethics. So these are the bulk, this is the bulk of what our curriculum entails for the first 3 years of their education here in the United States. And as I mentioned, the last year is experiential. So experiential curriculum does encompass a little bit of the first 3 years, and that's where we introduce interprofessional education. So as I mentioned, we have interprofessional education for pharmacy students where they are allowed to work alongside physician students, medical students, physician assistant students, and also physical therapy students here on our campus at least, and also nursing students as well. We have introductory pharmacy practice experience, and that was a change. When I was in pharmacy school, we didn't have introductory pharmacy practice experiences, but then the Accreditation Council for Pharmacy Education made those changes, I would say, in the last 10 to 15 years, where they wanted to introduce introductory pharmacy practice experience to expose students to what community practice is, what ambulatory care practice is, and what hospital practice is, to prepare these students and also to give them a visual picture of what these experiences will be upon completion of their degree. The last year of pharmacy school is advanced pharmacy practice experiences, and experiences can vary in length from anywhere from 4 to 6 weeks during that last year. I currently serve as a hospital preceptor, so I take students for a 5-week rotation where I practice internal medicine. So internal medicine means that I work alongside a physician. I also work alongside medical residents and medical students who are involved in patient care. So I see a wide spectrum of disease states, or at least we follow in terms of internal medicine, can vary anything from diabetes management, infectious disease, cardiology, anticoagulation. Sometimes we also see oncology, although that's not my expertise or my area of practice. Again, I introduce students to a wide variety of disease states through their exposure in the hospital. So it's a very interesting and very dynamic experience that students get a chance to see that. Other experiences here in the United States that are offered during that last year include ambulatory care. Ambulatory care is an area of practice that has really seen a tremendous growth development in the last 20 years. So ambulatory care is where pharmacists are trained in disease state management, primarily chronic disease state management, such as diabetes, cholesterol lowering, hypertension, heart failure, endocrine disorders. So again, where they are also allowed to develop collaborative practice. So collaborative practice means that pharmacists are allowed to modify or change drug therapies on the patients that are followed by physicians. Oftentimes, physicians will send a referral to a pharmacist in the ambulatory care setting for further management. A good example of this would be in warfarin management, also diabetes management or hypertension dose management, where the pharmacists actually are able to modify, change therapies under the agreement with an established agreement that that works alongside a physician. Other types of experiences would be community. So as I mentioned, community practice, we also refer to that as retail, where students are working in these retail stores. We also have them in nuclear pharmacy, industry, if that's available. So again, a wide spectrum of opportunities that are offered to PharmD students. I included this slide. This is actually a slide that I have given to my students here at the college. I tell them that it's very, very important that they put on their best behavior, that they make a good impression to these prospective employers when they're on their rotations. So whether they're on an introductory experience or even an advanced pharmacy practice experience where they're spending 5 weeks at a clinic, maybe 5 weeks at a hospital practice, it's very, very important that they make their best, give a very good impression, because again, I tell them that that could be considered a mini interview. Making a good impression, especially with clinical managers, staff employees, or maybe even an administrator, can eventually lead to a position. And I've actually seen many students have the good fortune of securing positions through these types of introductory pharmacy practice experiences, where I've seen administrators come to me and say, Sam, we really like the student. I think the student really shines. The student really has potential. Maybe we would consider giving the student an opportunity to work with us. And I've seen many students get secure positions upon graduation. So it's a very worthy and worthwhile chance for students to shine. And again, these are things that we tell our students to really focus on, and also to make a good impression once they leave that bubble of the pharmacy school and also get out into the real world. In terms of licensure, so again, after graduation, so upon completion of the Doctor of Pharmacy curriculum, the students, graduates are expected to pass exams. So each state has a state board. So as you know, we have 50 states here in the United States. So the pharmacist licensure is actually determined by all 50 states. So each state has their own regulatory board. For requirements for practice are set by the boards of pharmacy, which includes a graduate of an ACP accredited school for new graduates, and then the exams. The two biggest exams that we have here in the United States is called the NAPLEX, which stands for the North American Pharmacist Licensure Examination. All graduates of every pharmacy school is expected to take the NAPLEX upon graduation, and successfully passing the North American Pharmacist Licensure Examination, or NAPLEX, will allow them the chance to reciprocate. So once they take the NAPLEX, they do not have to take that exam again. So that's just a one-time examination that they would take. Now, every state has a law exam. The law exam is basically the multi-state pharmacy jurisprudence exam, where state boards have set certain rules, regulations for the practice of pharmacy in terms of dispensing, and this pertains to the regulatory affairs and also rules for dispensing medications to patients. So that includes narcotics, the rules that are set for refills of medications. These are all set and established by the state board. So what that means is that every state has their own exam. So what that means also is that if I was originally licensed in the state of New Jersey, which is where I grew up, when I worked and did my residency training, I was expected to take the law exam, or the MPJE, in Pennsylvania. And then upon completion of my residency training, I moved to the state of Georgia. So when I moved to the state of Georgia, I was expected to take the law exam for the state of Georgia in order to receive my license. So I had licenses in 3 states. Currently, I have 2. in terms of practice. And then only 2 states in the United States require a compounding exam. So the compounding exam is basically the student's ability to verify prescriptions, also dose calculations. And again, this is something that only 2 states in the United States require as mandatory, and that is the state of New York and the state of Georgia. So only 2 states require this compounding wet lab exam. In terms of reciprocity, so reciprocity allows pharmacists to become licensed in multiple states. As I had mentioned, I was originally from the state of New Jersey. So after graduation, I did work in the state of New Jersey and took both the NAPLEX and the NPJE in New Jersey. When I moved to the state of Pennsylvania for my residency training, I took the MPJE, or the law exam, for Pennsylvania, became licensed in Pennsylvania for 1 year. And then again, I reciprocated to the state of Georgia, where I currently am, where I had to take the law exam for the state of Georgia. It does require score transfer of the NAPLEX. So as I mentioned, if you take the NAPLEX once, successfully pass it, you are not required to take the NAPLEX again. The only thing that is required would be the MPJE, or the multi-state jurisprudence exam for each state that you are applying to. Now, in terms of foreign pharmacist requirements, they do make it a little bit more difficult for pharmacists coming from other countries. I know many relatives and also many friends, even members of our church, who did pharmacy in India or maybe abroad. They are required to do internships, so they are required to do practice for 1 year, usually in a community setting, in a hospital setting, to obtain the required internship hours. They are required to take the foreign pharmacy graduate equivalency exam. They have to take the test of English as a foreign language. And then upon completion of those, they are eligible to take and sit for the NAPLEX and also the law exam, the MPJE, for the state that they are currently applying to. So as I mentioned, the role of pharmacy is so dynamic, and also in terms of the areas of practice. I often tell my students to find that area of interest that they have in terms of practice, and also where they want to find their specific niche. So niche means that their particular interest and where they would like to practice. When I was a student, I wasn't sure. And again, most of our students really don't have an idea of where they want to practice because they are young and sort of naive in the career, and also in terms of what pharmacy practice is and what pharmacy practice has to offer them. We are lucky here in the United States to have so many different areas where pharmacists have opportunities to pursue fields in areas such as managed care, ambulatory care, as I mentioned, where they work collaboratively with physicians in chronic disease state management, community practice, where they have the opportunity to own their own pharmacy and also to run their own drugstores, academics, which is where I currently serve and practice, administration management in the healthcare setting, and then obviously for those who pursue PGY2 or second year specialized training in different areas of pharmacy practice, such as critical care, infectious disease, cardiology, oncology, psychiatry, emergency medicine. There's so many. I haven't even listed all of them, but again, many areas of pharmacy practice that have an opportunity to, with specialty training for pharmacists to pursue. So a question often comes up from our students, should I pursue a residency or should I pursue a fellowship? The history of residency started as early as the 1930s, so several years ago here in the United States, almost 100 years if you think about it. But in 1962, the American Society of Health System Pharmacists made the process more formal through accreditation standards. And the reason that we have these standards is really to train pharmacists in direct clinical practice and also management. Every residency program has a teaching component. Usually our program is sponsored by the university, which is where I work, but our residents practice in the hospital setting. So our residents do have a teaching component where they are allowed to teach in some of our courses. I usually give, as a program director, I do give our residents an opportunity to choose from various courses and also based on their clinical interest. So if a student has or if a resident has an interest in teaching in diabetes management, or if a resident has an interest in teaching oncology topics, I usually have them paired with a faculty member who is coordinating that course and allow them to work with them. Every residency program is required to have a research requirement. And so in our program, what we do is we have our residents complete 2 research projects. Now, the research projects that most residents and even myself included have completed are mostly retrospective data collection in terms of patient outcomes. Many of our research programs and research opportunities are more in the arena of quality improvement, patient outcomes, process improvement, and these are really the areas where pharmacists can make a big role and a big impact in terms of patient care. And really, the purpose of residencies here in the United States is to prepare our clinical practitioners for that advanced specialized training, and then also to prepare them for board certification. So really, that's the overarching goal of our PGY1 residency programs. Now, fellowships, and I'll talk a little bit about fellowships on the next slide as well, really are more postgraduate programs designed to develop independent researchers. Many of our drug companies are the ones who sponsor these fellowships. I come from the state of New Jersey, where we have many drug companies, many pharmaceutical companies that are partnered with Rutgers University. Rutgers University is the state university of New Jersey, which is where I'm from. And they have many built-in partnerships with pharmaceutical industries, which offer these types of fellowships, which can either be 1 or 2 years in length. Again, focus is on planning, conducting, and reporting research. They usually allow the residents or their fellows to be principal investigators. And again, they do have a teaching component since it is affiliated with the university. And their fellowship programs can vary anywhere from 12 to 24 months. And so the question often comes up, and I think I heard this in the beginning of the introductions and welcome, where you were talking about accredited versus non-accredited programs. Now, here in the United States, also that question does come up in terms of accredited programs versus non-accredited programs. The American Society of Health System Pharmacists is ASHP. I'll mention ASHP quite a bit through my presentation. Establishes standards. So the standards basically are meant to build on Doctor of Pharmacy educational outcomes. They establish these standards through a set of criteria that every program undergoing a appraisal has to meet. Define standards in terms of educational outcomes, and some of the areas that are surveyed include the requirement, the selection of residents, also the responsibilities of the program to the resident, the design and conduct of the residency program, the requirement of the residency program director and preceptors that are involved in the direct clinical care of the clinical training of the resident, the requirements of the clinical practice site. So again, even the site where the resident is training has set standards that they must adhere to, and pharmacy services. And pharmacy services primarily relate to the quality of care that is provided by the hospital site. So I've actually participated in 2 ASHP accredited residency site surveys where we went through a very rigorous process in terms of the accreditation standards. They reviewed our materials, and as a program director, I was responsible for putting the materials together to ASHP in order for programs to be accredited. And successfully, we were able to meet those requirements. We met all the educational outcomes, and we were granted the maximum cycle of the accreditation period, which is 8 years. So we were very happy. And again, it's a collaborative effort. It's not one person, it's multiple people that are involved in the development of an accredited residency program. Because again, our goal, our focus is really on the training of future residents and future pharmacists. Non-accredited residency programs do occur, and they actually are available here in the United States. Many of these non-accredited residency programs choose not to go through that external validation or appraisal from the accrediting body. They do have a little bit more freedom in terms of learning experiences. There's much more flexibility. So again, our residents in an accredited program have very fixed modules that they have to complete before completion of the program in order to get their certificate of achievement. The non-accredited programs mostly are going to be sponsored by some colleges of pharmacy. Maybe some hospitals may choose to pursue non-accredited residency programs. They also will have a wider applicant pool. So again, those who are applying for non-accredited programs have a better chance. So they have a wider applicant pool. So as I mentioned, the American Society of Health System Pharmacists is the accrediting body. And again, I don't need to read this information to you, but again, as the accrediting body, setting the standards for pharmacy practice and also the training of residents is critical, especially in terms of our goals and the objectives that we are setting for the training of our future pharmacists. Some of the benefits of postgraduate training, again, a lot of times many students may ask me, they call me Dr. John. So again, I'm very informal, but they call me Dr. John. So Dr. John, why should I pursue this? And I do tell them that especially the advanced clinical training is something that you won't get again. In terms of the opportunities that are given to you, the opportunity to conduct research, scholarly activities. One of my goals for our residents is really publications, and I would love to have our residents perform a body of research and then have that turned. One of my requirements is the development of a manuscript that is worthy of publication. And so what I do is I want to emphasize to my postgraduate students, my residents, that we want to turn your research projects into something that we can publish and put out there in terms of patient care and also in terms of quality improvement. As I mentioned, many residency programs offer the ability to teach or give those opportunities to our residents. We're also actively pursuing board certification for residents. And again, that's basically an exam, which I'll go over in the next few slides, and also to prepare our residents for PGY2 fellowship training. Even though these are optional, we do encourage and we really want to promote our residents to the highest level of quality care for pharmacy. And so again, really the board certification and preparation for PGY2 training is our goal. That's our overarching goal. And also in a very complicated and oversaturated job market, the requirements now have changed. When I first graduated from pharmacy school, it was very easy to get a hospital job. And I'm sure Dr. Thomas Jose, I call him Jose Uncle, would agree. 20 years ago, 15 years ago, 10, 15, 20 years ago, very easy for pharmacists to get a job. There was such a wide demand for pharmacists. The salaries for pharmacists were very high. I remember there was a time where many of these retail stores, community pharmacies were giving sign-on bonuses, offering newly graduated pharmacists cars, vehicles to join to work for them. Those days are gone. Those days are gone. We don't see those days anymore. In fact, now the salaries of pharmacists have come down due to the oversaturated job market. Now, in an oversaturated job market where the demand for new graduates is not as high, there's an increased emphasis on this type of residency training. So again, having a doctor of pharmacy degree seems to be the norm across the board, across the spectrum. Now it's the advanced qualifications. What type of additional training, what type of additional opportunities did the graduate pursue? So those are things that we are increasingly seeing, especially in terms of the requirements for hospital practice, academics, even industry. Pharmaceutical industries may often require a postgraduate training at least 1 to 2 years before joining. So as I mentioned, the benefits of residency training due to the competition, we have more pharmacy schools now in the last 20 years than we did before. There is a declining opportunity for new graduates, unfortunately, due to this oversaturated market that was really created by this high demand, not enough positions in practice. So definitely the advanced clinical training, as I mentioned, offered through residency training, either a PGY1 or PGY2 training, is going to be a requirement for most healthcare organizations, especially larger academic healthcare institutions. Here in Atlanta, I know that we have several hospitals, healthcare systems that will only allow PGY2 trained pharmacists to go to the floors and work alongside physicians. That's a requirement. Whereas in academia, there's also a requirement to have that advanced training. And the reason for that is really, in addition to training, my responsibility, in addition to teaching, one of my responsibilities with my job, or at least a job description, is also the training of students in terms of practice in clinical pharmacy and also the hospital site that I'm attached to. And as I mentioned, industry fellowships also require at least 1 year of PGY1 residency training. As a program director, I just wanted to show you what I look at and in terms of what my requirements would be for applicants who are applying to our program. So that includes the official school transcript, and this is pretty standard for every program. Every program director will look at these four qualities, these criteria. I do tell students that a competitive GPA is above 3.5 on a 4.0 scale. So again, that would be listed as competitive. In an increasingly high demand market, I tell students often with 3.0, 3.1 GPA that they may not be considered competitive. And also if they're looking in bigger cities, I often tell students to possibly look outside of the city, maybe look even outside of the state, as there are opportunities. But again, the more competitive programs will look at those students with the higher GPAs. Letter of intent is also an important factor because, again, the applicant should be very specific as to why they're pursuing that program. So very specific in terms of the learning experiences that are offered, in terms of why that resident feels that that program is the right fit. Letters of recommendation are also going to be important. I do spend quite a bit of time reading letters of recommendation from our applicants and also from preceptors, because again, as we are enrolling our residents, as we are interviewing our residents, I really want to make sure that the person that works with me for 12 months is someone that has good recommendations and also letters of support, strong letters of support. So I do tell students that when they are asking either an employer or maybe a professor or maybe even a clinical pharmacist that they have worked with, to make sure that that person who's writing the letter is going to strongly support their application. So again, that's a conversation that usually is between the student, the candidate, and also the person that is writing the letter. And also the CV. Curriculum vitae, we do spend a lot of time in terms of developing CVs for our students. So it's very important that students build their CV. And you can tell the difference between someone who has a very sloppy, poorly developed CV versus someone who has a more robust and also very dynamic CV. You can see the difference in terms of how much time they spend on developing that curriculum vitae. The matching process. So again, I don't need to read through all of this information, but again, as I mentioned, we go through an online centralized application service. That's for the resident and that's also for the program. And also basically we have a pre-interview score. So pre-interview score is where I would review the student's application in terms of the transcript, the letter of intent, the letters of recommendation, and also their CV. So these would factor into a pre-interview score. So the pre-interview score is is a numeric scale. And then based on those numbers, I can then determine if I'm going to interview the top 10, maybe the top 15% of the applicants that have applied to my program. The interviews, we usually traditionally interview anywhere from 15 to 18 applicants for 2 positions. So again, that could be anywhere from 8 to 9 applicants for those 2 positions. And then after the interview, we basically come up with an interview score, a clinical exam. Maybe we also do require our residents to present a clinical case to us where we can evaluate their presentation skills, which is big for our program. It's highly valued, especially in terms of their teaching style and also things that we can focus on during the residency year. The match, so we do go through a similar matching process like the medical residents. So again, similar to what goes on in the United States for medical, graduate medical education training. Pharmacy also goes through the same type of national matching services where a program director and also the applicant would submit their ranking of the top candidates or the top programs in terms of a match. And the match results are released to us in March. So in March of each year is when I receive the results of who matched with our program. And that's the same across the United States. So the same goes for the medical residents as well. Just to show you the demand, I got this from, and I received this information from the American Society of Health System Pharmacists newsletter this year, that this year we actually matched in this country close to 4,000 positions. So 3,741 positions were matched. And then also with PGY2 positions, so that's that second year training, we had about 1,380 positions that matched with us. In the United States, just to show you how much residency programs have grown over the last 6 years, so from 2015 to 2020, PGY1 residency positions have grown by 27%. So because there is such a high demand, there's such a high demand for residency trained pharmacists. The American Society of Health System Pharmacists has been a huge advocate. They've been a huge advocate, a huge proponent of advanced clinical training for pharmacy graduates. And then also, in addition to that, between the same year, 2015 to or same time frame, between 2015 to 2020, PGY2 positions. So that means our second year focused training programs have grown by 56%. So even bigger demand for ambulatory care services, infectious diseases, critical care, and then others. Some new programs that I've seen in the last maybe 2-3 years in terms of PGY2 specialized training here in the United States focuses on emergency medicine, pain management, and also palliative care. Which are arenas that we probably maybe 10, 15 years ago never thought pharmacists would ever enter. But now there's been such an expansive growth in these areas of pharmacy practice. So as you can see, very highly specialized, very sophisticated in terms of the level of training and also practice that pharmacists here in the United States are able to engage in. So again, fellowships really are more about developing research skills. We do have two types of fellowships here in the United States. A traditional fellowship is usually associated with a school of pharmacy. 2 years in length is usually the time frame where a fellow, we call them fellows, would be involved in research and teaching. So they are developing their body of research, being able to publish that research, and then in addition to that, have an opportunity to serve as an adjunct faculty position with teaching responsibilities at the college or the university. In addition to that, we also have industry fellowships. So industry fellowships are sponsored by the drug companies, the pharmaceutical drug companies. But again, their focus is going to be more on company operation. Several of our fellows, many of my colleagues work for some of these companies such as Pfizer, AstraZeneca, and again, their fellowship opportunities allow them to work and network with overseas. They're allowed to work in drug development. They're also involved in regulatory affairs. A lot of them have travel opportunities. So again, very exciting, especially for young new graduates who are trying to get their feet in the industry, pharmaceutical industry. So again, many opportunities. And then as I mentioned, ASHP is the accrediting body. They also sponsor something called a meeting referred to as the mid-year clinical meeting. American Society of Health System Pharmacists is the largest professional organization for pharmacists, and they offer a annual meeting. Our annual conferences is in December of each year in various cities throughout the United States. Unfortunately, for the last 2 years, the pandemic has affected us. So with COVID-19 and especially with cases rising, they decided to offer this in a virtual platform. Last year was the first time they offered it in a virtual platform, and we were just notified last week that this year, again, due to the Delta variant and also with the numbers of unvaccinated individuals here in the United States, that they just felt it was not safe to conduct a meeting that would probably draw about 25,000 people. So they decided to go again virtually this year. So again, the ASHP meeting is really geared, very highly geared towards students and also with resident training and also with interviews. It's a wonderful opportunity for students and residents, a wonderful conference for them to attend. Now, as I mentioned, board certification. So again, it is a credential that is for licensed pharmacists. It is optional. It is not requirement for practice as a pharmacist. But I will say that many hospitals, many areas of pharmacy practice, especially in terms of hospitals and also in terms of academia, may look at board certification highly in terms of the credential. So very similar to the physician certification with the American Board of Medical Specialties, similar to that, we have now a Pharmacy Specialty Council. It is a validated certified exam developed by a specialty council, which includes content experts, so usually specialists in various fields, and also psychometric consultants. So again, this exam, which comprises about 250 questions, is considered the gold standard, the advanced practice qualification for pharmacists in terms of practice. And once a pharmacist is certified, they are required to maintain that certification or recertify every 7 years. So once certified, we are required to maintain that certification every 7 years. So it is a clinical exam, high emphasis on biostatistics, drug literature evaluation, But again, the content focus is going to be on pharmacotherapy. There are a number of certifications. The current list from BPS, or Board of Pharmacy Specialties, are listed there for you. So again, applicants can choose from any one of number of exams, including pharmacotherapy, ambulatory care, oncology, psychiatry, critical care, nutrition support, cardiology, infectious disease, and others. So one of the newest exams that have just been released or in development from BPS is going to be emergency medicine. Solid organ transplant also was released, I think, 2 years ago, and other exams that have also been in BPS's list include pediatrics and geriatrics as well. So in terms of the role, I wanted to define the roles of traditional pharmacy services here in the United States. We do have a dispensing role, which is operational. So again, dispensing would be more on the side of verification, a process order entry from physicians, or even our mid-levels. Mid-level practitioners can also prescribe here in the United States. Mid-level practitioners include your physician assistants and also include nurse practitioners who work alongside practice with a physician. There is also a high emphasis on sterile product compounding. In fact, in our pharmacy schools, we do place a huge emphasis on sterile product compounding because we know that most of our graduates are going to enter the community practice or even the hospital arena for practice as a pharmacist. Medication reconciliation, drug information, medication stocking of automated dispensing cabinets in the hospital systems, formulary management, and also supervision of students and technicians are going to be primarily the roles of a operation or dispensing pharmacist. Now, I wanted to compare and contrast that with clinical roles. So clinical roles in terms of clinical setting, clinical pharmacists here would include multidisciplinary patient care rounds where they are rounding with a physician. So that's direct bedside patient care. And as I mentioned, that direct bedside patient care that is offered by a pharmacist, usually the requirement would be residency training. So in terms of residency training, board certification would be requirements for a pharmacist to be serving that type of consultative or even a surveillance role. Other responsibilities include renal dosing, pharmacokinetic measurements and dosing of medications. Antimicrobial stewardship is a huge component of what pharmacists in the hospital do. Medication counseling often is required, anticoagulation monitoring, nutrition support services, where pharmacists actually can serve on nutrition support teams. When patients are required to be on total parenteral nutrition, it's often the pharmacist that's involved, working with a dietitian or maybe a registered dietitian, working with them in terms of meeting their protein goals, carbohydrate goals, and also their nutritional needs in order to get them properly treated. Training of residents and students also is a big role for the clinical pharmacists. Participation in health system committees. So here in the United States, we have Pharmacy and Therapeutics Committee, which involves pharmacists, clinical pharmacists, and also physicians, where they make the deciding rules, make the policies in development for safe practices in the healthcare setting. They're also involved in research and drug studies and also educational activities to medical and nursing staff. So I wanted to finish up with examples of clinical pharmacy services and introduce a patient case to you. So we have a 45-year-old male patient who was admitted to the hospital for management of a weeping lower extremity cellulitis. So this is a skin and soft tissue infection. In the emergency department, the patient spiked a temperature. So he had a temperature reading above 100 degrees, and the pharmacist was consulted on appropriate dosing of empiric antibiotics for this patient. And this is something that is very common here in the United States, where pharmacists are called upon to help with dosing and also the initiation of empiric antibiotics while the patients are in the emergency department. His past medical history is significant for hypertension. He also has atrial fibrillation and congestive heart failure. So his home medications that were provided to us on admission include lisinopril, 20 milligrams that he takes by mouth once a day for hypertension and heart failure. Spironolactone, 25 milligrams PO once daily, which he takes for hypertension and heart failure. Furosemide, 20 milligrams by mouth once daily for heart failure. Carvedilol, 25 milligrams by mouth twice a day for hypertension and heart failure. Warfarin, 5 milligrams by mouth once daily for atrial fibrillation. and he takes oxycodone, acetaminophen, which brand name here in the United States is Percocet, which he takes as needed for pain. So as I mentioned, that the pharmacist was asked to consult on this case in terms of empiric dosing of antibiotics. And as you can see, we don't have a lot of information on this slide. So again, the only things that are listed are the past medical history, his current condition, which is the cellulitis, and also his home medications. So home medications were provided to us on admission. So some questions that I would ask as a pharmacist to the medical team would be current blood pressure readings. So again, that's something that can easily be obtained by the nurse. Also, a question to ask the medical team would be his current ejection fraction. We know that he's already on a heart failure regimen. One thing we would want to optimize while the patient is here in the hospital, or at least evaluate, would be optimization of his heart failure regimen. Is he on goal-directed medical therapy? So it appears that he's on the right medications. Is he at the current doses or the correct doses in terms of patient outcomes? Probably the most important thing here outside of his antibiotic selection and dosing would be his INR. So INR, as we know, is going to be the anticoagulation monitoring tool that we will see. It's a lab value that we look to assess the level of anticoagulant activity in the patient. So before anything, that would be probably one of the first things that I would want to obtain. So in terms of patient parameters to obtain would be this patient's baseline INR. We know that he's on a drug, warfarin, which is an anticoagulant. We know that anticoagulant specifically has a very specific monitoring goal of 2 to 3 for patients with atrial fibrillation. So my question in my mind would be, where is he currently at this dose and what level would he be? In terms of drug dosing for the empiric antibiotics, one of the first things that a pharmacist would do would be to calculate his clearance. And again, that would be an estimated creatinine clearance, which is really an estimate of his renal function. Because again, we know that many of these drugs that patients are initiated on, especially in the hospital setting, can affect the kidneys. So we refer to them as nephrotoxic drugs. We want to make sure that the patients are dosed appropriately based on the indication and the treatment options. His height and weight would be needed for dosing calculations, and also important would be allergies to medications. The reason that we emphasize allergies to medications is that we want to make sure that the appropriate antibiotics that we select would not be contraindicated if the patient does have any medication allergies. In particular, one big thing that we do see here in the United States often is penicillin. So when patients have some type of hypersensitivity or maybe an anaphylactic reaction to penicillin, many options may be off the table. So that means that many options that we would want to choose may not be the wisest in terms of the patient's allergy history. So again, here what we want to emphasize would be pharmacokinetic, pharmacodynamics, properties of these drugs that we're about to initiate, general approaches to infectious disease, the testing, microbiologic culture data, and also antimicrobial stewardship. Antimicrobial stewardship is an arena of pharmacy practice that has really seen a tremendous growth over the last few years. And I'll talk a little bit about antimicrobial stewardship in the pharmacy practice. So as you all know, pharmacokinetics is the relationship of the antibiotic concentration to time. Oftentimes when we teach our students, I tell them to remember 4 things. We want them to remember absorption, distribution, metabolism, and excretion. So how is the drug absorbed? What is the distribution of the drug? How is the drug metabolized? And also how is the drug eliminated? So absorption, distribution, metabolism, and excretion or elimination are going to be the 4 principles of pharmacokinetics. In terms of pharmacodynamics, we know that that's the manner in which the antibiotic would interact with the target organism. So again, we have antibiotics that are either bacteriostatic, where they basically inhibit the growth. We also have bactericidal antibiotics that will kill the organism. And then also a big emphasis would be combination therapy. So in terms of this patient case, for the patient with a weeping cellulitis, again, we don't know what the organism is. We haven't identified that based on culture sensitivity data from the microbiology report. So again, we want to empirically cover with broad agents. Primarily, we want to use combination products to overcome any type of resistance patterns, specifically with gram-positive and gram-negative organisms. So in the sample patient case, again, applying pharmacokinetic or pharmacodynamic relationships, again, looking in this table, we know that certain antibiotics exhibit different types of properties. So again, when we're looking at initiating agents, are we going to choose a bactericidal antibiotic or bacteriostatic? Again, that decision is really up to the physician. So again, pharmacists are called upon to consult, to act in the role of surveillance in terms of applying pharmacokinetic principles and also determining the most appropriate antibiotic for the patient. So just some general approaches to infectious disease, again, is when would we initiate antibiotics empirically would be for those patients who have a fever. If the patient also has an elevated white blood cell count and also culturing suspected sites. So obviously that would entail obtaining blood cultures for patients if we are suspecting any type of bacteremia. If the patient is experiencing urinary symptoms, we are suspecting a UTI, we would also want to culture the patient's urine, and then also sputum. If we are considering patients who are here with pneumonia symptoms and we want to empirically cover the patient for treatment of pneumonia, again, culturing the patient's sputum if possible. And again, the principles of empiric therapy is really to start antimicrobials before the offending organism has been identified. Oftentimes the rule here is that we want to obtain cultures. So obviously we don't want the antibiotics that are initiated to taint or to affect the blood culture, the cultures that we're obtaining. So here what we would want to do is make sure that the cultures are drawn appropriately before the antibiotics are initiated. And obviously, pharmacy works very closely with the microbiology lab. Oftentimes, I'm reviewing patient culture data, especially in terms of susceptibilities. And also, once we get the report of the antimicrobial, in terms of antimicrobial susceptibilities and also resistance patterns, we want to make sure that we're able to identify definitive therapy, which means that we can narrow or de-escalate antibiotics to the spectrum to the most appropriate narrow choice. In terms of antimicrobial stewardship here in the United States, really the primary goal is to optimize clinical outcomes. We want to minimize any adverse effects of agents, including toxicity, and also we want to prevent any type of pathogenic organisms and the emergence of resistance. And unfortunately, resistance is a huge factor in our healthcare settings. We often do see the development of multi-drug resistant organisms, and really the fault there would be in terms of overprescribing antibiotics, even extending duration of antibiotics beyond the intended use or duration of therapy. One of my goals, especially when training pharmacy students, is always to evaluate the number of days of therapy of antibiotics. If we are initiating empiric antibiotics, we should have a definitive time frame. So again, is it going to be 3 days versus 5 days? Again, the purpose, the intent of looking and evaluating at the number of days of therapy is really to prevent resistance, because that is what we are trying to overcome. In terms of goals of antimicrobial stewardship, in addition to our primary goals, some of our secondary goals would be to reduce healthcare costs. We know that healthcare is very expensive here in the United States. That's one of the driving forces in terms of impact in terms of economy. So we know that reducing healthcare costs is going to be one of our goals without adversely impacting quality of care. Core members of our antimicrobial stewardship team would obviously be an ID physician. So that's usually our champion, someone who is trained and expert in infectious disease matters, alongside clinical pharmacists with infectious disease training. Other members would include a clinical microbiologist. We also have computer specialists, information technology specialists, as well as an epidemiologist if available. So it is a well-designed collaborative teamwork between the stewardship team, infection control in the hospital, and also the pharmacy and therapeutics committee, who really evaluate resistance patterns. We also are involved in the development of antibiograms, where we're looking at susceptibilities. We're looking at data over a year or two in terms of what would be the most appropriate agents to use in terms of specific microorganisms to cover. Core strategies would obviously be the implementation of formulary restrictions. Here in the United States, general medicine doctors are not allowed to prescribe all antibiotics. We do have certain antibiotics that are restricted to only infectious disease specialists. In addition to that, outside of antimicrobial stewardship, we also have certain drugs that are restricted to cardiologists. We also have certain drugs that are restricted to nephrologists. So again, depending on the indications, depending on the medication, we do have restrictions in place for even physicians. So it's not that all physicians can widely prescribe anything. Again, the purpose of that is to prevent the overprescribing of antibiotics or medications and the development of resistance. And then other strategies in terms of antimicrobial stewardship would be education, the development of guidelines, order forms, and also the big emphasis obviously would be streamlining and de-escalation of antibiotics, and also getting the patients, switching the patients from an intravenous dose of medication to something that they can take by mouth. So we have our patient parameters here. So we know that he's a 45-year-old male patient. He measures 74 inches or 188 centimeters. He weighs 79.5 kilos. His chemistry 7, so was obtained, and it looks like his chemistry 7, his electrolytes are all within normal limits, and his serum creatinine is 1.1. So we do look at serum creatinine in terms of dosing our patients. So in terms of dosing calculations for a 45-year-old male patient, two things that we want to focus on would be the ideal body weight. What is this patient's ideal body weight? And that is provided by a formula. So for a male patient, it would be 50 plus 2.3 times the height over 60 inches. So here in the United States, we do go by the metric system. So we also look at inches in addition to looking at centimeters. But again, in order to plug this formula into this formula, we would look at his height over 60 inches. So based on this formula here, his ideal body weight is 82.2 kilos. Now we're going to use that ideal body weight to plug into an estimate of his renal function. So we use something called the Cockcroft-Gault equation, which is an estimate of the patient's creatinine clearance, where the three parameters that we would look at would be his age, his weight, and serum creatinine. So his age, the weight, and serum creatinine were all provided in this example. So by plugging in the formula, so 140 minus the patient's age of 45, multiplied by his weight, his ideal body weight is 79.5 kilos. So I'm actually going to be using his actual body weight here since it's less than his ideal. And then we're going to divide that by 72 multiplied by his serum creatinine value, which gives us an estimated creatinine clearance of 95.4. So before we initiate antibiotics, it's very important that these parameters, patient population estimates are done in terms of dosing of medications. And again, this is where pharmacists are called upon to evaluate the appropriate dose and also the efficacious use of medications based on his renal function. So in terms of dosing of appropriate trough levels for vancomycin, so again, we know that for empirically covering for staph infections, especially the possibility of maybe MRSA, which is methicillin-resistant Staph aureus, what we want to do is determining appropriate levels. So what that includes would be our definitions of appropriate trough levels, which is really how we're going to estimate the patient's efficacy in terms of toxicity. With skin and soft tissue infections, we usually set a goal of 10 to 15. And then for bacteremia and pneumonia, something more serious obviously would achieve a higher trough level. So usually those would be 10, 16 to 20. Now, in terms of monitoring for the trough levels, those were really decided by three organizations. We have the Infectious Disease Society of America, that's abbreviated IDSA. We also have ASHP, which is the American Society of Health System Pharmacists. And then we also have the Society of Infectious Disease Pharmacists. So these three organizations came up with these goals, which have been implemented for the last 10 years, 10 or more years, in terms of identifying the appropriate levels at which these drugs would be used effectively in terms of its killing properties. So we know that vancomycin is a bactericidal agent. So again, what would be the most appropriate levels for treating a skin and soft tissue infection versus something that would be more serious? So obviously we know that we're treating a cellulitis, which is a skin and soft tissue infection. So our goal should be anywhere in the range of 10 to 15. And that's been established by IDSA, which is the Infectious Disease Society of America. What we do not want is we don't want levels less than 10. So the reason that we don't want levels less than 10 is that there has been reported resistance when levels of vancomycin are obtained that fall below that 10 micrograms per milliliter value. So again, based on those studies and based on resistance patterns, it was determined that for less serious infections, but at least cellulitis, skin infections, an appropriate goal would be anywhere from 10 to 15 micrograms per milliliter. And obviously for more serious infections such as bacteremia, pneumonia, sepsis, or even a bone infection such as osteomyelitis, you would want to target a higher trough level. So what are some of the pharmacokinetic principles with vancomycin dosing? So I wanted to give you an example of how I would evaluate this patient. So if this was a patient that was on our service, I would look at a few things. In terms of vancomycin for the volume of distribution, we know that the volume of distribution is basically an important indicator of the extent of drug distribution into body fluids and tissues. So with population estimates, I'm using a value of 0.7 times the patient's estimated renal function, or the creatinine clearance that I calculated, comes out to be about 56, so 56 liters. The next thing I would want to look at is the patient's elimination rate constant. Now, the elimination rate constant represents a fraction of drug that's removed over time. So again, here I calculated that based on the patient's estimated creatinine clearance. I multiplied that by population estimates to come up with a value of 0.084. So what that means is that 8.4% of the drug would be removed each hour. So in every hour, or each 60-minute time period, 8.4% of vancomycin would be removed. The next thing I would look at is incorporating the elimination rate constant by dividing that by the half-life. So the half-life would be 0.693 divided by the elimination rate constant would give me a value of 8.3 hours. So what that means is when we're looking at the half-life of a medication, as you all know, the definition is the time that's necessary for the drug concentration in plasma to be reduced by 50%. It is an important parameter that relates to the rate of elimination. So again, it's very important when it comes to drug dosing in terms of evaluating the drug's half-life. So again, when we're looking at dosing the medications in terms of the frequency or the schedule, looking at the drug's half-life. Does the drug have a short half-life? Does the drug have a long half-life? So that'll depend on whether we're going to dose a medication a certain number of times a day. So here, for initial dosing of vancomycin, what I would do is I would take 1.5 or 1.5 multiplied by the patient's or the drug's half-life. So here we calculated 8.3, and so we would multiply that by 1.5 and come up with 12.5 rounded to 12 hours. So here in the hospital setting, we like to round it to either 6 hours, 12 hours, or 24 hours for the most convenient dosing schedule or interval, especially for nurses. When nurses are administering the medications, when they're hanging it, oftentimes it gets confusing if it's every 6 hours, every 4 hours. So what we do is we like to make it a little bit more straightforward in terms of entry into the computer system and also for the administration by the nurse. So 12 hours would be an appropriate dosing interval based on this patient parameters. And then the next thing we would want to determine is a loading dose. So vancomycin is a dose that we would load at a dose of 20 milligrams per kilogram. So we know the patient's weight. And so what we would do is we would just multiply that by 20. So 20 would give us a value of 1590. And here in the United States, what we do is we round in 250 increments. So that means 250 milligram increments, anywhere from 750 milligrams, 1,000 milligrams, 1,250 milligrams, 1,500 milligrams, 1,750 milligrams, and the highest that I've ever seen is 2,000 milligrams of vancomycin for a dose on a patient. Now, because this this value ended up being 1,590, instead of going down, I would actually round up. So I would actually round up to the next or nearest 250 milligrams, giving me a value of 1,750 milligrams as a loading dose. For maintenance dose, we would choose 15 milligrams per kilogram. So 15 milligrams would give us based on the patient's weight, would give me a dose of 1,193 milligrams. And as I mentioned before, we would round that up to the nearest 250 milligrams. So I would round that to 1,250 milligrams as a maintenance dose. And then obviously we would want to check steady state concentrations. So steady state would be achieved in 4 to 5 half-lives. And we are assuming that this patient has good renal function based on the creatinine clearance that I calculated. So again, in about 4.5 lives, when the patient is probably received a number of doses, so anywhere from 33 to 42 hours, we can basically then check a vancomycin trough level. And here in the United States, by measuring the trough level, which would be the level right before the patient receives their 4th or 5th dose, we usually time that drug sample to be about 30 minutes. So we want to time it 30 minutes, maybe even an hour before that next dose. And that would then determine if the patient is accumulating. So if the patient is accumulating, we know that they're exceeding the goal level, which is anywhere from 10 to 15. So many situations, sometimes mistakenly, the nurses would draw a peak level. Here in the United States, we do not draw peak levels anymore. When we're looking at vancomycin dosing, really we're going to be looking at the trough level, which would be the level the lowest level that would be obtained before the 4th or 5th dose. So in this example, so again, 1.75 grams or 1750 milligrams IV as a loading dose is what we would give. And then we would follow that with a maintenance dose of 1,250 milligrams or 1.25 grams IV every 12 hours. And that's based on our pharmacokinetic dosing calculations from that previous slide. Now, that would provide our coverage against gram-positives. So gram-positive organisms, empirically, we're covering. We want to overcome any resistance. So again, empirically covering for methicillin-resistant Staph aureus, which is notorious here in the United States, especially in many of our patients. And then the second agent that we would use would be an agent that would empirically cover against gram-negative agents. And here in the hospital, we use an agent called piperacillin tazobactam. The trade name of that here in the United States is Zosyn. So piperacillin tazobactam, based on this patient's renal function, would be dosed at 4.5 grams IV every 8 hours. So the patient received this regimen for 3 days, and after 3 days, the lesion has actually shrunk, the redness has improved, and the pain is now managed with analgesics. As I mentioned, we wanted to wait until the patient achieved steady state. So again, the trough level, which was drawn appropriately, came back on day 3 with a reported level of 12. So that means that the dose was appropriate. And again, we met that goal of 10 to 15. A couple of other parameters I want to introduce here is that his INR, so again, remember that the INR is the level of anticoagulation, since the patient is on a medication called warfarin, was 2.5 on admission, but today it's 2.8. So we know that the goal for patients with atrial fibrillation is 2 to 3. Now that is the same goal when we're looking at patients with DVT, which is deep vein thrombosis, pulmonary embolism. Again, it would be the same goal for those patients who are on those drugs, on warfarin. Today, he's afebrile, his white blood cell count is within normal limits. So now is an appropriate time to make a determination, to make a good clinical decision as to what we should do with his antibiotics after receiving 3 days of IV antibiotics. So now the blood cultures that have returned are negative. So blood cultures are negative, but the culture that was obtained from the edge of his lesion grew out Staphylococcus aureus. So we know that this is a gram-positive organism, and we have the following microbiology culture and sensitivity report. So in terms of the sensitivities, we know that based on the microbiology report listed here, we know that the Staph aureus that grew from the lesion, his infection, is resistant to 2 antibiotics. It is resistant to clindamycin, and it is resistant to oxacillin. So because it has resistance to oxacillin, we know that now we can identify this as methicillin resistant. So methicillin resistant means that we cannot use any penicillin derivatives. We cannot use anything related to oxacillin in terms of covering for this patient's infection. So we know that we have to use different agents based on this sensitivity report. So we would refer to this as methicillin-resistant Staph aureus because that resistance to oxacillin confers that resistance. So now we have 4 options based on this microbiology report. So the 4 agents that we have options would include rifampin, we have tetracycline and tetracycline derivatives, trimethoprim sulfamethoxazole, and vancomycin. So he's already been initiated on vancomycin, so at least we know that he's initiated on an appropriate agent. Currently based on this sensitivity report. So again, applying antimicrobial principles. So because we know that this patient has methicillin-resistant Staph aureus, we do have 4 options. So the first option we would look at is rifampin. Now, the reason that we would avoid rifampin in this patient is that we know that rifampin is associated with high resistance rates, especially when used alone for staph infections. Now, we do use rifampin primarily when used for tuberculosis. We do use rifampin sometimes in synergy for patients with more serious infections. But again, for a cellulitis patient, we would not use rifampin alone because of the high risk and rate of resistance. The second agent or option that we have here is trimethoprim sulfamethoxazole. Now, trimethoprim sulfamethoxazole is a widely used antibiotic here in the United States. It goes under the trade name of Bactrim. It's a highly successfully used antibiotic used to treat both MRSA infections. It's also used to treat E. coli. So when patients present with urinary tract infections, maybe a cellulitis that has methicillin-resistant Staph aureus growing, trimethoprim sulfamethoxazole would be an appropriate choice. So wide use for Bactrim. Unfortunately, in this case, we would want to avoid the use of Bactrim, trimethoprim sulfamethoxazole, primarily for the reason of a drug interaction. We know that trimethoprim sulfamethoxazole, when used in combination with patients who are on anticoagulants such as warfarin, can actually cause an elevation in the patient's INR. During this patient's hospital stay, we saw that the patient's INR went from therapeutic values, it stayed within therapeutic values, but still continued to climb up. We know that Bactrim or trimethoprim sulfamethoxazole can actually cause bleeding and cause an elevation of the INR. So that's something that we would want to avoid specifically in this patient. So we would want to avoid trimethoprim sulfamethoxazole. Now, we know that the patient was already on IV vancomycin, which was used appropriately as an empiric option. But again, now around day 3, we want to think of how we would send the patient home. We would want to discharge the patient home on an appropriate oral option. Now, unfortunately, oral vancomycin is not an option because the only reason or indication for using oral vancomycin would be for the treatment of Clostridium difficile. So again, a GI infection that patients experience. So again, a oral option of vancomycin would not treat this patient's cellulitis. So again, vancomycin IV is appropriate in the healthcare setting, but when the patient goes home, we have to think of something else. So then our final option would be a tetracycline. So here, the best option for this patient would then be to de-escalate from the vancomycin IV and then switch him to doxycycline 100 milligrams. So again, a course of treatment would be anywhere from 7 to 10 days, which the patient can take. And again, doxycycline is a very relatively inexpensive medication that the patients can receive, and they can complete a course of therapy in the outpatient setting. So in conclusion, again, after this patient case, I just wanted to introduce the training, the credentialing of pharmacists in the United States. It's definitely modeled that of medical physicians over the last several years. The practice of pharmacy has definitely moved beyond a traditional dispensing role, more into a clinical role, supervisory role, administrative role. In terms of our training and education, there's definitely a high level of sophistication, especially as a respected healthcare worker and also alongside members of the healthcare team. And some future considerations definitely would be in the United States would be provider status. That's something that some of the legislative committees are evaluating in terms of pharmacists being able to bill for pharmacy services that are provided. Those are things that are going on discussions here in the United States. So with that, I will conclude. I want to thank you so much for your time and wanted to see if you had any questions for me.
Sam, I think you forgot two things you missed.
Yes.
For the MTM services and
yeah.
pharmacist-led clinics, right?
Yes. Yes. Dr. Jose was talking about medication and therapy management. So that's a certification that's been a big movement with clinical pharmacy services in the outpatient setting. So again, that's more in the ambulatory setting where now medication therapy management is a certificate program. Actually, I also took that offered through the American Pharmacists Association, and that has been a big movement in terms of therapeutic management, drug dosing, drug interactions, Another thing that Uncle had mentioned was, remind me again, Uncle, the second part.
Yes, definitely. But Sam, overall, it's an excellent presentation. You reflected the true color of what is going on in the United States. Very excellent presentation. I'm really
Thank
proud
you.
of you, and I'm happy that you could do it in an excellent way. Thank you very much. Appreciate it.
Thank you. Thank you. Yes, and I've listed my email there. So my email is samueljo@pcom.edu. If you have any questions, if you want to email me with anything specifically related to this or maybe practice here in the United States, again, that's something that I would be more than happy to share with you. Please let me know if you have any questions.
So kindly students, if anyone have any queries or doubts regarding these webinars, you can raise your questions now.
Hello, sir. Good
Hello.
evening.
Good evening.
So we have got in our hospital, we are getting many vancomycin resistant cases as well, samples. So we go for usually we go for teicoplanin, right, sir? So do you have any cases with teicoplanin resistance as well?
Is it vancomycin resistance? Is that what you were asking about?
Yes, sir.
Yes, we are seeing several cases of vancomycin resistance, especially enterococcus is something that we're seeing. We actually do have certain medications in our hospital setting, but again, those would be restricted to infectious disease. As I had mentioned, whenever we see cases of resistance, especially with vancomycin, maybe sometimes even aminoglycoside resistance, what we do is we would consult infectious disease. There are agents that are used to treat vancomycin resistance. I didn't include those in this presentation, but again, it is something that we are seeing emerging. Primarily what we would use would be things such as daptomycin. We've also used linezolid as agents, as options. There are several agents to use. Many of these agents, unfortunately, are going to be restricted. So obviously that would require a high level of expertise, someone who is familiar with dosing and treating these types of special cases. So again, we do see it as well. Unfortunately, resistance is something that I think every healthcare setting around the world is going to see. And that's the reason that there's been such a big push with antimicrobial stewardship, appropriate use of antibiotics. We want to limit the duration of even agents that we're using to treat UTIs. You know, we think of UTIs, we think of pneumonia as fairly benign, easy disease states to treat empirically. But again, the problem that we see, especially when patients come back, when patients are readmitted within 30 days, within 60 days, is primarily the development of resistance with these organisms. It's very hard to isolate these patients. Sometimes we do have isolation rooms. I will tell you that in the era of COVID, it's been extremely difficult, especially when COVID now has been our top priority, especially for pharmacists and physicians and nurses. It's taken quite a toll on our healthcare system. And again, you know, managing these, you know, antibiotics, managing these resistance patterns is going to be a huge role where pharmacists can play. So again, there are agents. If you need me to send you some information, more than happy to share that with you.
Thanks.
Is there any other person with doubts, please?
Were there students on this call as well?
Yes.
Yes, sir.
Okay.
Yes.
Okay.
Is there anyone?
Hi, sir. Good evening.
Good evening.
So I have a question for you.
Sure.
Like, how important is pharmacogenomics, and is there something that we can, as students, go and learn, you know, about the types of drugs that require pharmacogenetic intervention, like dosing calculations, like for example, TPMT dosing in TPMT testing in azathioprine dosing. Like we're not taught about that in college. We don't have something like that. So any kind of reference or textbook that you would suggest?
Yeah, and also here in the United States, I don't think I never received that type of training. That was something that I infrequently encounter. We actually do have a push now towards introducing that. I believe in most courses or colleges of pharmacy, it may be an elective course where if a student is interested in pursuing that type of, we do have assigned faculty. I personally am not involved in those courses in terms of teaching, but I can find those references. So if you want to send me your email, I can probably point you in the direction of someone who can answer that question in terms of genetic testing and also resources which are available. I do know that in the area of HIV pharmacotherapy, that also has become a huge teaching point. That's something that I remember our infectious disease physicians at the hospital, they'll have pharmacists involved with that in terms of obtaining, in terms of selection of the most appropriate agents due to genetic testing. Yeah, that's something, it's a great question. Unfortunately, I can't answer that, but I can find that resource information and send that to you.
Yes, sir. Thank you, sir. I would drop down an email to you
Yes.
if that is
Yes.
fine.
Absolutely.
Then you can call.
Yes. Thank you.
Thank you. Thank you so much, sir. Thank you.
Thank you.
So there is a question.
Sam, I will
from
talk to you
Dinesh.
later. I'm getting out now. Okay.
Okay. Okay. Thank you.
Thank you. Bye.
So there is a question from Dinesh Kumar stating that do we need to do a residency program to become a board certified pharmacist?
Okay, that's a good question. No, you do not need to complete a residency training to obtain board certification. The requirement for sitting for the board certification exam, I believe, is 3 years of pharmacy practice. So if you're working as a pharmacist, at least for 2 to 3, I believe 3 years is my understanding, is that you are eligible to take. So they take that experience that of 3 years worth of pharmacy training, pharmacy practice, as equivalent to residency training. So you are not required to do residency training for board certification.
So there is a next question from Ashwati stating, kindly tell us about the PhD after PharmD in the US and the exams that we must appear for.
So PhD is Doctor of Philosophy. So that is not a requirement for pharmacists in the United States. The Doctor of Pharmacy program, as you all know, in education here in the United States in pharmacy schools, we have two departments. So we have the Department of Pharmacy Practice, which I am a part of. So that's our PharmDs. And then we also have our PhDs. So PhDs are going to be my PhD colleagues are the ones who teach most of the basic sciences. So they teach microbiology, immunology, pathophysiology, pharmacokinetics. So they're the ones who teach in those courses in pharmacy school. It is not a requirement for PharmDs here in the United States. If you want to pursue a PhD, it's usually those who want to go pursue teaching, maybe bench research with a pharmaceutical company. Then you would complete your PhD program, and then you would also be required to then obtain the post training after the PhD, postdoctoral training in terms of the in order to teach. So that would be a requirement for PhDs. Again, that would be more if you are interested in drug development, if you are interested in industrial type of research, or if you want to teach in the pharmaceutical sciences department, the PhD with postdoctoral training would be a requirement. Did that answer that question from Aswati? Did that answer your question? Okay.
Yes, sir. Thank you, sir, from Ashwati.
Yes.
Is there anyone? So there is a question again from Dinesh stating, after becoming a registered pharmacist in Canada, working for more than 3 years in community pharmacy, can we apply for DCP and become a BCPS?
Yes. So again, the requirements for board certification is at least 3 years of pharmacy practice. So they don't look where you've worked. They don't look to see if you've worked in community pharmacy, if you worked in hospital pharmacy. The requirement is at least 3 years of pharmacy practice. So you are eligible to sit for the board certification exam. Yes.
Thank you, Sam. Is there any more questions?
Is there anyone else?
Anyway, Sam will be associated with our association for the future programs. He is always
Thank you. Thank you.
Okay. So thank you, sir, for such a insightful as well as a very informative session, which is being shared towards us. You covered an all-around topic regarding the education for the pharmacy graduates, that is pharmacy graduates, as well as for the PG training, as well as the pharmacist, importance of pharmacist license, as well as the residencies versus fellowship, the difference between both accredited versus non-accredited programs available, as well as the benefits of postgraduate training, as well as the requirements, and the way we should analyze a case if we get, and the clinical pharmacist pattern or the practices which is carried out in the US. So it has been a very good informative session for each and everyone. Thanking from each and everyone from my side. Thank you so much, sir.
Thank you. Thank you for the opportunity. It was my privilege to come and speak to you today.
Thank you so much, sir. And now going towards the next session. So I'm welcoming Dr. Jomin George Joseph for vote of thanks. So Dr. Jomin Joseph completed pharmacy degree from Pushpagiri College of Pharmacy and postgraduate from St. James College. He worked as a production manager at Encare Medical Devices, and after which joined Pushpagiri College of Pharmacy as assistant professor and also clinical coordinator of Department of Pharmacy Practice at Pushpagiri Medical College Hospital. So Dr. Jomin sir, I kindly invite you for the vote of thanks session.
Thank you, Dr. Ashtami, for that wonderful words. And it's an honor for me to have been asked to offer the vote of thanks on this occasion of the second international webinar conducted by the Doctor of Pharmacy Association. And as we have already extended our thanks unofficially to all the members who have gathered here. So this is actually as a part and officiating or official statement of thanks to all those who have participated here. And first of all, I extend my extreme thanks and gratitude on behalf of the Doctor of Pharmacy Association to our honorable and respected chief guest, Dr. Sam Jones, for his wonderful session, which may be an encouragement to all the students who have gathered here so that they can arrange and adjust their curriculum and put efforts in identifying the areas where they should know more about the future of this pharmacy program. And also, I would like to thank Dr. Jay Shagar, the president of IPA, for inaugurating this session. And we are happy to have you, sir, over here in this session. Followed by that, I would like to thank Dr. Elizabeth Faber for delivering the welcome address. And also, I thank the moderator, Dr. Ashtami, for organizing this program in a well and effective manner. So as a whole, I would like to say that the Doctor of Pharmacy Association is performing tiresome work to promote this profession in our country, India, and have achieved many extreme levels to help, especially those who are in practice, and also for those who are about to grab the degree and enter in the practice. So may this be an encouragement to all those office bearers as well as the members of this association to uplift the profession to a next level so that we could achieve all those designated theoretic aspects in practice, and also we could make others aware the importance of this profession and also improve the patient care to an extreme height. So may this be an encouragement to all of you, and I extend special thanks to all the office bearers, especially to Dr. Noble Scaria and his team and other team members from the student section as well as the academic section, and also the government officers who are a part of this association. May all our combined effort produce a great impact in our government and also to promote the profession to an enormous height so that many students get benefited when they completed their degree and they could have a feeling that their degree is an asset and Thereby, we can modify the existing healthcare to an international standard. And I extend my thanks again to Dr. Sam John for this wonderful session, and may this be continuing throughout our period, and we'll be organizing many webinars similar to this, along with other aspects which will be effective and useful for the students. By this, I would like to conclude and thank you for your patience, and may God bless you all, and have a good night.
Thank you so much, sir. All the participants are kindly, please do fill your feedback form for receiving your e-certificate. And once again, thank you so much for all the pharmacy graduates, the listeners, the viewers, the wonderful presenters, and from the Doctor Pharmacy Association. Thank you for making the webinar a wonderful success. Thank you and thanks a lot. Have a nice day.
We will keep in touch with you. And thank you once again, thanking all